So the arachnoid granulations which develop in early life, the arachnoid granulations develop in the SSS if the flow is routine or normal or slow. If the vein of Galen is not helping the SSS absolutely in draining out the blood of the brain, then SSS has to take the brunt, because of which the arachnoid granulations do not develop, and when arachnoid granulations do not develop, they are unable to resolve ESF, because of which there is dilatation of the ventricles. Extremely rarely you will find that there is a mechanical obstructive hydrocephalus in this case. It's ventricular dilatation. It's like, you can call it hydrocephalus, but it is not obstructive hydrocephalus. It's a ventriculomegaly. So eventually, if you leave them, then the ventricles will go on dilating, the parenchyma will go on thinning, the parenchyma will have venous ischemia, which will lead to calcifications. It will lead to developmental delay, irritable seizures, and eventually the child will never have a normal childhood or normal adulthood. In clinical features, most of them, because of the large ventricles and the sutures not being closed, most of them will have large heads, because the thin bones, they are not sutured, so they will go on expanding, and the child will have a large head, and he's unable to hold his head despite being 6 months, 8 months old. Because of the high shunt, there might be heart failure. Seldom the heart failure is refractory to treatment. That becomes an emergency for us to treat. But otherwise, most heart failures either do not need any treatment, or they can be easily treated by pediatric cardiologists. Rarely, there might be a seizure. So how do we treat the vein of Galen aneurysmal malformations, which are mural? As I said, mural are single hole fistulas. Here we use the catheters which are over the wire. That means the catheters like SL or Echelon. We use the 14 wires, any 14 wire of your choice. We use over the wire catheters because we need a large amount of concentrated glue to be deposited in a very short time in order to close the fistula. And also, when we use the braided strong microcatheters, they do not stick. We place it close to the fistula but not at the fistula, because as you start injecting glue, the catheter might get sucked in, and then it becomes difficult to close the fistula. So keep it proximal, and we use concentrated glue 75 to 90%. The injection is fast, absolutely no venous access here, absolutely no coils here. People have used it many years ago, 20 years ago, and have had hemorrhages and deaths. You should get a mushroom-like cast to close the hole, and post-op, maybe for 24 hours, the baby should be ventilated, kept sleeping, and gently woken up. We have to do a CT scan, because sometimes what happens is they go down because of the closure of the fistula, and they can have subdural connections. In mural vein of Galen's, you expect a very high cure. In fact, you should expect a cure nearly 100% per session. Choroidals, as I said, it's a different disease altogether. You use different microcatheters like marathon, like supple microcatheters over smaller wires, because you have to go more distal, and you have to use concentrated glue in order just to skeletonize, or in order just to occlude the arteries, not to get into the veins. And this is a piecemeal. This is like you have to do 3, 4, 5 sessions on kids in order to control it. You may not cure these. As I said, the good time to treat them is at 5 to 6 months. Emergency will happen if there is refractory cardiac failure, and emergency will happen if the referral comes too late. That can happen when suddenly the head size goes smaller. That can happen when the sutures close. Ventricles go on dilating, the sutures are closed, the parenchyma of the brain, it goes on shrinking, and that is the time that we have to treat these kids in emergency. But that is generally the time that the kids will be 2 to 3 years of age. The good time to treat them is 6 to 8 months. So even if the kid is diagnosed antenatally with ultrasound, MR, and very concerned parents and pediatricians have come to you with the diagnosis even before the birth of the kid, you must tell them that the only reason The indication to treat vein of Galen so early in neonatal age is if there is cardiac failure and the pediatric cardiologist has told you that he is unable to control it. That's the only indication. Let the kid grow up a little, and at 6 to 8 months is the perfect time to treat them, and if it's a mural type, to cure them. Like this kid, large head, and came in with a diagnosed vein of Galen. There is no other diagnosis, just one. There is a pineal region, huge aneurysmal dilatation of the vein of Galen. There is ventriculomegaly, and you can see how the brain is tight. No sulci are seen. This is the angiogram. There are better angiograms after this, but you can see that there is no nidus-like structures anywhere, just the arteries leading to the huge brain aneurysm. And you can see here, this is where actually there is a shunt inside the vein of Galen aneurysm. So you have to use over-the-wire catheter. Keep it just proximal to the fistula. You always put a small curve on the catheter so that the first burst of glue which comes out, it doesn't go straight in the lumen, but it actually sticks onto the wall and you have better control. And then from this position you can inject glue and you can close it. After the first injection, this is what we have. Seldom you require 2 injections. This is the second injection. Again the same thing. A little proximal curve on the microcatheter, and all you need to do is get a mushroom inside this, and you have closed it. This is after second injection. You may not have complete cure, but as long as it looks like this, 60 to 80% reduction in flow, then you can leave them and rest assured that the malformation is going to get closed in time. The angiogram shows exactly that. So in 3 months later, the MR shows that there is complete thrombosis of the aneurysm, and over the next 6 months or 1 year, large aneurysm is going to go down in size and you won't recognize it on imaging. Here, it has already started to regress. You can see the sulci now, you can see that the ventricular size is smaller, and you can also see in follow-up the patient is doing better. Complete thrombosis, and on follow-up angiogram, of course, angiographic cure. And here the follow-up, as I said, on follow-up you won't be able to recognize there was a huge tomato-shaped aneurysm over here. It shrunk completely, allowing the kid to grow normally, and it's extremely rewarding. I think all the cases that we do, small little kids like these, when they go to school and they come back on follow-up to you, I think that's the most rewarding time that we have. Follow-up MR showing complete cures. Another one of the same. Now I'm not going to repeat, you already know, this is just for reiteration. Large ventricles, small parenchyma, huge vein of Galen aneurysms. This is the angiogram. You know that you have to go towards the highest flow artery, and you have to leave the catheter over here. This is the shunt, this is the fistula, and once you do that, you have to get the microcatheter up to here and use concentrated glue. This is the one. You can see that the small little curve on the microcatheter. One shot, one injection, and full cure. And key, of course, is the cast. It's a mushroom-like cast. This is the artery, this is the hole, and this is the proximal part of the vein. You can see that this is such big aneurysm, and exactly at the hole it's been plugged with concentrated glue. And when you do that, you have full cures.